Well, we continue our discussion on glomerular diseases, and before I discuss the next topic regarding glomerular disease, I have some questions. You can stop the video to read the question and answer your question also. This question number 1, okay, answer your question. This is question number 2, and now this is question number 3. Right. So I hope you have read all the question and done the answer. So let's discuss this topic. Topic of discussion now here is membranous glomerulopathy, also known as membranous glomerulonephritis. Let's learn the basic concept about this topic. Well, it is a very common cause of nephrotic syndrome in Caucasian adults. Okay. One thing that means this is a disease of the youth of the adults. This is in contrast to in that the part 1 we talked about minimal change, where that disease was primarily occurs in children between the age of 2 to 8 years. Well, now let us see what are the causes of this condition. It is usually idiopathic. Majority of the time there is no reason, as high as 70% cases. We don't have any reason, it's just idiopathic. But otherwise, there are certain secondary causes. In the secondary causes, infections, especially hepatitis B and C. Point to be noted that minimal change glomerulonephritis is not caused by B and C. Well, it can be caused by sometime by malaria also. Then this can be caused by certain systemic autoimmune diseases also, like SLE, like rheumatoid arthritis. It may occur in Sjogren syndrome also, again a type of autoimmune disease. This can be caused by certain cancer, neoplasia, like colon, breast, lung, stomach. Okay. This can be caused by certain drugs also, especially penicillamine or non-steroidal anti-inflammatory drugs. This can lead to. There are certain miscellaneous causes, and the most important disease that belong to this category is diabetes mellitus. Now let's learn what the basic pathology of this disease. So before I discuss the pathology, let's learn what the normal histology. Okay, so in the normal histological examination of the glomerulus, okay, so this is the epithelial cell, and this is the foot process. Epithelial cell, foot process, and this happened to be the glomerular basement membrane. Glomerular basement membrane, this particular structure. And here is the capillary endothelium. And this is the capillary lumen. CL stands for capillary lumen, where the blood is flowing. And this is the wall of the capillary which is facing toward the basement membrane. It is this particular entity which has got the pores. This is the mesangial cell. MC stands for mesangial cell. And here is the connective tissue, so-called mesangial matrix. Okay, so this is normal histology. Now what happened in membranous? Now let's look about pathology. In this, there is subepithelial deposition of antigen antibody complex. You can see subepithelial deposition. What do you mean by subepithelial deposition? Antigen antibody complex, so-called immune complex, This is the epithelium, this is the basement membrane. It is below the epithelium, that's why we call it to be subepithelial deposition. And one thing you must have noticed, the deposition, the feature, if you look under the black, they are like this. They are like this. And this is so-called spike and dome pattern. Okay? It's classical that you can appreciate. And that lead to thick basement membrane. GBM. Thickening of GBM occurs. That's a classical feature. Okay, this is what I hope you understood the basic concept about pathology. With this, let's talk more. So in the biopsy findings, what we get is uniform diffuse thickening of the glomerular capillary wall. On light microscopy on H&E staining, that is hematoxylin eosin stain, without an increase in cellularity. This is very, very important. Again, we go back to basics. This simply thickening of the basement membrane by deposition subepithelial, but as such there is no increase in cellularity. And this very important point that you got to remember now, that there is no increase in cellularity. And if you look at the electron microscopy, thickening of basement membrane caused by irregular dense deposit laid between basement membrane and epithelial cell, so-called subepithelial deposition, which I mentioned just now to you. Okay? And this is so-called spike and dome pattern. In fact, whenever this is a very classical Usmle question, where if you are in the pathology, you are getting spike and dome pattern. That means 99.9% you are dealing with membranous glomerulonephritis. This is a catch point. This you can't afford to forget. And immunofluorescence microscopy will reveal that these granular deposits contain immunoglobulin, IgG, and C3. They are immune-mediated problem. Okay. Now let me show you a beautiful picture. Well, it's normal with this capillary endothelium, yellow color, and this gray color is basement membrane, and this is the epithelial cell with the foot processes. Okay, and now this antibody is coming, antigen is there, and they get deposited. And look, what is the site of deposition? Epithelial cell, and this is the glomerular basement membrane, and they are getting deposited here. So-called subepithelial deposition is there. So I hope now you understood the meaning of subepithelial deposition, which lead to a thickening of the basement membrane. And now one more beautiful picture, again a normal finding. And now you can see this is the space where it is going to get deposited like this, so-called spike and dome pattern. Spike and dome pattern. So this black color that you are seeing in this particular picture, that beautifully depicts spike and dome pattern. So I hope with this beautiful picture and before that line diagram must have clarified your basic concept. Okay, so with this background, now we talk about more about immune complex, which is nothing but antigen antibody I described to you. Now we go to some basic concept which is really meant for top rank student like you. So in this, we mentioned about autoantibodies in the previous slides. Now let's learn more about autoantibodies. Serum autoantibodies to M-type PLA2R, that is anti-M-type phospholipase A2 receptor antibodies are there in these patients. It is a major antigen in the pathogenesis of idiopathic membranous. This is very, very important. Okay, so the PLAR antigen, and we have antibodies against PLAR. But point to be noted, this is seen only in idiopathic variety. And remember, just to recall you, 70% cases are idiopathic and 30% are secondary. And these antibodies, they are present only in primary, that is in idiopathic variety. they are not present in secondary. In fact, if you are getting in any question PLAR, PLA2R antibodies is virtually diagnostic of primary idiopathic membranous glomerulonephritis. So till now there are two cache points. Spike and dome pattern is nothing but any type of membranous glomerulonephritis. But if you are getting antibodies against the PLA2R, that means you are specifically talking about primary membranous glomerulonephritis catch point. Okay, and as I told you, these antibodies are seen in idiopathic variety. They are not present in secondary. These antibodies are highly sensitive and specific to diagnose primary membranous glomerulonephritis. And these antibodies are mainly IgG4. This again a point that you got to remember. And they lead to immune deposition in the glomerulus, contributing to the development of the disease. This is IgG4. Now, not only this, there are certain other autoantibodies are also there. And other antibody involved is neutral endopeptidase antibodies. One more thing. Sometimes the antibody may come from outside the body, and they are cationic, bovine serum albumin. They come from cow milk or beef protein. They can also contribute to problem of this problem. Okay. With this background, now let's look into a beautiful picture of pathology. Look at this yellow mark, and they indicate membranous glomerulonephritis. Subepithelial deposition is seen. Now let's talk briefly about the clinical picture what we have. In this case, patient come with edema, nephrotic range proteinuria, that means more than 3.5 gram per day, but it is non-selective proteinuria. That means not only albumin comes out, other proteins also come out. Okay. An additional thing that we have, that patient has renal failure, hematuria, and abnormal urine sediment may develop later. Point to be noted that in case of minimal change, there was selective proteinuria, no hypertension, no hematuria, and no renal failure. And one more thing, in this case, in this that complement level is normal. It is not reduced. Now in these patients, renal vein thrombosis is a big problem. This really need to understand the basic pathophysiology. Well, as I told you just now, there is loss of, it's a non-selective proteinuria. That means there is loss of albumin, A for albumin. But other protein also go out, that is antithrombin 3. Antithrombin 3 is also secreted in the tubules. And we all know very well that antithrombin 3 is a very powerful anticoagulant, natural anticoagulant in the body. Okay. And one more thing, fibrinogen is not filtered. It remains in the body and antithrombin 3 goes out. We all know very well that fibrinogen is the one which is a procoagulant. And this is anticoagulant. Okay. So that means the body is more prone to thrombus formation. So there are two factors which contribute to clot formation. And one of the common site of clot is renal vein thrombosis. Okay. So in this case, well, renal vein thrombosis occur as a manifestation of this hypercoagulable state. How does patient come to us? Patient come with sudden onset of abdominal or flank pain. Okay, the pain is really very severe, very severe pain. Unbearable pain occurs. And when the renal vein thrombosis occur on the left side, and that really impedes the venous flow from left testes also, and that lead to left-sided varicocele. This need to be understood. So this is left testicular vein. This drains into left renal vein, left renal vein, left testicular vein, and this goes into inferior vena cava. But in contrast, on the right side, this is right testicular vein, and it drains directly into right testicular vein, and it drains the right testicular vein, it drains directly into the inferior vena cava. That's the reason why in nephrotic syndrome, left-sided renal vein thrombosis will lead to left varicocele. Complement level are normal. I mentioned earlier also how we really treat this condition. It's immune-mediated phenomena. We give immunosuppressive therapy. Prednisolone or corticosteroid are the mainstay of treatment. If otherwise, we can add cyclophosphamide or mycophenolate also. And in some cases, we may even add rituximab also. Right? Prognosis: about a third of untreated cases, they have spontaneous resolution. About 1/3 they progress to chronic renal failure, and 1/3 they continue to have proteinuria without progression to chronic renal failure. That means they keep on having proteinuria without any CRF. So a quick recap of the last minute revision point. Nephrotic syndrome in adult, non-selective proteinuria, idiopathic, serum antibody to PLA2R is virtually diagnostic of primary or idiopathic membranous glomerulonephritis. In secondary causes are hepatitis B, C, and cancer, and renal vein thrombosis is a big problem. Okay. With this background, now let's discuss the questions, what you have read it. Question 1, what the most likely reason for this problem, patient problem? Answer is membranous glomerulonephritis. Why it's the answer? Let's learn the basic. Correct answer is C, membranous glomerulonephritis or glomerulopathy. The keywords are 52-year men. Remember, membranous occurs in adults, more in Caucasian males. Colonic cancer, the patient is suffering. Again, cancer is a predisposing condition. Generalized edema because of proteinuria in the range of nephrotic syndrome. Glomerular wall thickening without increase in cellularity is a classical feature of membranous, no cellularity. And why thickening of basement membrane? Because of subepithelial deposition and spike and dome pattern, what he's talking about, which is virtually diagnostic of membranous. By this, whatever picture we got it seemed to be a case of secondary membranous glomerulonephritis. Why secondary? Because of colon cancer. And why membranous? Spike and dome pattern. So, as I told you, nephrotic syndrome, proteinuria, and spike and dome under malignancies to talk about secondary. What about option A, Membranoproliferative glomerulonephritis? Okay, in this we get hypercellular glomeruli or because of tram tract appearance. I have recorded a separate lecture for MPGN. You can see that also. So that's why MPGN we call it to be proliferative. But remember, in case of membranous, there is no increase in cellularity. Okay, and in membranous, thickening of basal membrane without increase in cellularity. Option B is incorrect. Berger disease is a manifestation in children 1 to 3 days after upper respiratory tract infection. An IgA deposition is seen in mesangium, which is not. And remember, IgA nephropathy doesn't occur in colonic cancer patients. Minimal change disease, again, the most common cause of nephrotic syndrome in children. No abnormality seen on light microscopy. And electron microscopy, we see effacement of the podocyte, so-called fusion of foot process. Option E, multiple myeloma. It doesn't produce spike and dome in the histology. So this is not the answer. Question 2. We get a 62-year obese. Answer is membranous nephropathy. Keyword in this question are 62-year obese woman, edema, significant proteinuria, which explain why patient has proteinuria. Serum contain IgG4, which are seen in membranous, and antibody to PLA2R, which is virtually diagnostic of primary membranous. If you are getting this line, straight away with a great confidence you can mark that you are dealing with primary, because this is seen only in membranous. So we can very comfortably say that we are dealing with membranous, and this antibody are not seen in any other thing. However, I will discuss other points. This is seen in hepatitis C, mixed cryoglobulinemia. It causes MPGN. It does not lead to membranous, and there is deposition of IgM, and that lead to cellular proliferation. And again, PLA2R is not seen. Minimal change, fusion of foot process, no association with PLA. SLE, well, in SLE, class 5, membranous nephropathy can occur in around 10 to 20% case of lupus. But it is a secondary cause of membrane, not a primary. And by now we have learned it that PLA2R antibody are seen only in primary, not in secondary. So they will not be there in secondary. So this is again ruled out. But again reminding second time, membranous glomerulopathy can occur in SLE. E is again multiple myeloma. This antibody are not seen. Question 3. The correct answer is antithrombin 3. I think we discussed in detail. 32-year man, membranous, already there. Sudden onset of flank pain that indicate renal vein thrombosis. Gross hematuria, left-sided varicocele. This also says that patient develop left-sided renal vein thrombosis. No, okay, by history only. Increased proteinuria, that is a feature of nephrotic syndrome. So by this now we are sure about it, that why we are dealing with membranous, which is already given the question, and antithrombin 3 is the reason which I explained to you, right? So again, same what I mentioned to you regarding testicular vein going into left testicular vein, going to left renal vein, and that lead to left-sided varicocele. Okay, so this difference in the venous drainage also explains why varicocele is common in the left side, right? And renal vein thrombosis is a manifestation of hypercoagulable state. Ceruloplasmin level is decreased in Wilson disease. It has no role in the pathogenesis of renal vein thrombosis. Although due to non-selective proteinuria, ceruloplasmin level may be reduced because it's filtered out, but it doesn't contribute to renal vein thrombosis. Similarly, albumin goes out. In fact, this goes out in all type of proteinuria, but it doesn't contain doesn't contribute to renal vein thrombosis, but it can definitely can lead to negative nitrogen balance, but it is not a predisposing condition for any thrombus formation. Immune globulin are lost, okay, but that means nephrotic syndrome patients are more prone to infection, but it does not contribute to renal vein thrombosis. Same thing, lipoprotein loss is a common thing to happen in a nephrotic syndrome, and that contribute to hyperlipidemia. But this definitely doesn't contribute to hypercoagulable state. Okay, and whenever we have got this proteinuria is there and lipiduria, that gives rise to, if you look into polarized light, oval fed color bodies are seen as Maltese cross. Whenever you are getting a Maltese cross, that means you are talking about lipiduria, but this doesn't contribute to hypercoagulable state. So the golden line to remember: nephrotic syndrome, NS is nephrotic syndrome. In an adult with a serum antibody to PLA2R, this indicates idiopathic membranous glomerulonephritis. And spike and dome pattern in the histopathology is again membranous glomerulonephritis. Thank you very much for watching this.